Walk into almost any clinic, and you will find medical charts containing the exact same two words to describe a patient's skin condition: maculopapular rash. As a diagnostic tool, this phrase is practically useless. In strict dermatological terms, a true maculopapular eruption is a specific presentation, generally reserved for a narrow set of viral exanthems or drug reactions. Using rash as a catch-all forces a clinician to simultaneously consider hundreds of unrelated pathologies. Compare that to excoriated, annular erythematous plaques with central clearing. That precision instantly filters a massive, chaotic list down to a highly targeted diagnosis. In dermatology, precise physical description serves as a highly structured, objective language. It provides the specific data points required to narrow the search. This clinical language operates on a strict matrix of physical thresholds. Every lesion is categorized by its size, its depth, and its physical contents. We can derive the proper name of every primary lesion from first principles, simply by altering one physical variable in this matrix at a time. Mastering this standardized framework replaces visual chaos with a reliable, repeatable system for identifying disease. We establish the baseline skin architecture: epidermis, dermis, and subcutis. First, we alter color with zero elevation. A flat area under ½ centimeter is a macule. Expanding beyond that boundary, it becomes a patch, as seen in vitiligo. We now introduce solid tissue elevation. A small solid elevation under ½ centimeter is a papule. Expanding laterally without substantial depth forms a plateau-like plaque. Expanding in both width and depth into the dermis forms a nodule. Nodules present in two ways: exophytic, visibly elevated above the skin, or endophytic, sitting beneath the surface where they must be palpated to be found. For solid lesions, crossing an arbitrary ½ centimeter or 2 centimeter threshold dictates the diagnostic noun, moving the clinician toward different sets of possible diseases. Removing solid tissue, we introduce a cavity filled with clear fluid, or serum. A fluid-filled blister strictly under ½ centimeter is a vesicle. Expanding past that threshold, it becomes a bulla. Changing the clear serum to purulent exudate, pus, defines a pustule. A localized collection of pus that exceeds 1 centimeter in diameter and forms a deeper cavity escalates to an abscess. When evaluating red lesions, the physical contents determine the diagnosis. Clinicians must confirm whether the redness comes from vascular dilation, erythema, or from extravasated blood trapped in the tissue, known as purpura. Pressing a clear blast slide against the skin, dioscopy, reveals if blood is trapped. If it fails to blanch, blood has leaked into the skin. Non-blanching, pinhead-sized microhemorrhages up to 2 millimeters across are classified as petechiae. Larger extravasations of blood into the skin and deeper structures are ecchymoses, commonly known as bruises. These behave differently from wheals, compressible, evanescent elevations caused by dermal edema. Wheals are driven by fluid leaking into tissue, not blood. Identifying if a lesion contains serum, a visible accumulation of pus, or trapped extravasated blood differentiates inflammatory, infectious, and vascular disorders. Identifying the primary lesion, the noun of the sentence, is only the first step. Skin diseases evolve over time, requiring us to identify secondary features. Secondary lesions are evolutionary markers. A scale is a flake arising from the horny layer, while a crust is composed of dried blood or tissue fluid. Recognizing the depth of tissue loss is equally critical. An erosion represents the loss of the epidermis alone and heals without scarring. An ulcer involves the destruction of the underlying dermis, guaranteeing a scar. Once the primary and secondary features are defined, the clinician maps out the global arrangement, known as the configuration. Individual lesions will often organize themselves into distinct geometric patterns across the body, presenting as grouped, linear, serpiginous, meaning snake-like, or annular, ring-shaped arrangements. Applying this to our visual evidence, the primary structure is a flat, broad plaque, but the raised boardy edges eyesight into a distinct papular component. We assemble the terminology: the primary noun, the secondary adjective, and the configuration. By strictly adhering to this morphological syntax, we stop looking at a chaotic rash. We read the pathology of the skin as a precise, decipherable language.